People gain weight, they go through divorces, a child dies, something catastrophic happens. We're human. Things happen to us. Weight fluctuates, stress fluctuates, life fluctuates, but it's about kind of getting back on track and loving yourself enough to want to be around, to want to live a long life, to be around for your children, to be around for your family.
Wits and Weights community, welcome to another episode of the Wits and Weights podcast. Today, I've got a very special guest joining me. Dr. Tiffany Di Pietro is a triple board-certified cardiologist, internal medicine specialist, and nuclear cardiologist who's on a mission to help people achieve their goals through preventative measures. And when I came across Tiffany's work through a member of our community who recommended her from another podcast, I was immediately impressed by her passion for educating the public about health and nutrition and disease prevention. This is a woman who graduated Magna Cum Laude with a Bachelor of Science in Psychobiology at just 19, then went on to become the youngest graduate from the College of Osteopathic Medicine at Nova Southeastern University down in my home state of Florida. And you know how I'm drawn to overachievers. But what really drew me to Dr. Di Pietro was her focus on prevention when it comes to cardiovascular disease. In particular, she also tells it straight, and I know she's going to do that today. We're going to dive into some of the myths surrounding heart disease, like the idea that it's only a man's disease or you have to have symptoms to have a problem. Tiffany's going to share her best practices for nutrition and movement to maintain a healthy heart and effective ways to prevent cardiovascular issues. And then later on in the episode, we're going to step into the minefield of the big is beautiful movement and ask the question, can big also be healthy? As an assistant clinical professor at 3 medical schools, a medical advisor at a law firm, a regular medical expert on national media outlets, and so much more, Dr. Di Pietro has tons of experience and expertise to share with us. And I think you're going to love Tiffany's approach to healthcare, which I'll be honest, we don't always hear this from doctors on the preventative side. So she believes that helping people understand complex medical issues is the key to promoting better health outcomes. And she has a lot of positivity to go with it. And it's just what we need these days for anyone looking to improve their cardiovascular health and well-being. And I think you'll love the rule that she lives by, which is simply be nice. Tiffany, thanks for joining me on the show today.
What a nice welcome. Thanks for having me.
Absolutely. I know my listeners are going to love to hear all about this because we talk about heart disease sometimes as just a man's disease and not realizing it's really the number one cause of death for women as well, obviously. And there are a lot of other, scary statistics we can get into here. I do want to understand from you, why is it a concern just in general for the population? And then what the risk factors are that individuals have to think about before we get into, okay, how do we deal with that?
Sure. So, as you said, heart disease is the number one killer of women also in this country. And I feel like I say that on repeat, and yet I still feel like people don't know it. So it's a little frustrating. I think the societies for breast imaging and mammograms, they do a great job in October where everything's pink, 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 and everyone remembers to get their mammograms. But at the end of the day, more women die of heart disease and all forms of cancer combined. So I tell my female patients, it's great that you know when your last mammogram was, and it's great that you know that you're due for one. But you really should just know your cholesterol and know your blood sugar and know what your blood pressure is and what those numbers should be, and really kind of ask your doctor, what do I need to be worried about? What should I be focused on? What are these numbers and what should they be? As a little statistic, since 1984, which is before I was born, believe it or not, more women have died of heart disease than men in this country. And that's a staggering statistic. Forget just that, it's number one killer. More women actually die than men of heart disease. And I think that's partially education. And I think that's partially like we still, especially physicians, honestly, still don't think that when a woman coming in with chest pain or palpitations, that's kind of chalked up to be anxiety or something else. And there's a big lacking in medicine amongst even physicians kind of taking women seriously.
Yeah. And I understand what you mean, because just in my own family's history, I primarily think of, my grandfather who died of heart attack and heart disease on men's side. And I wonder where the stigma comes from. I'm curious if you know where that history comes from. There's a lot of stigma when it comes to women's health in a lot of areas that we're now trying to correct. But I'm just curious about that.
I don't. It's the reason I became a cardiologist is truthfully, I found that it was a niche that really I could make some difference in. I know it sounds corny and cheesy, but it's just the truth. And you see a lot more female cardiologists starting to graduate and come out as well. but it's still definitely even an underrepresented field amongst female cardiologists. If you go to the big cardiology conventions, it's like, 75, 80% men and 20% women. So I think as more females graduate as cardiologists, we'll kind of see the stigma hopefully start to dissipate some. But yeah, I don't know. I wish I knew the answer to that, but.
Okay. Yeah, no worries. Well, we can dive into the practical stuff and try to understand it here, as well as what people can do about it. But you mentioned blood work. I think, if anybody goes to like the CDC website or just Googles it, they'll, or even just from experience, we all have heard the main types of things to measure, right? Blood pressure, cholesterol, things like your weight and your activity come into play, alcohol and things like that. What would you say are the top 2 or 3 things that everybody should be measuring on a regular basis, as opposed to, say, over testing certain things and just getting freaked out? What are the things they really should be measuring? And then where does the distinction for women particularly come in with some of those measurements?
Yeah. So luckily, that's a very easy question. So
Okay.
blood pressure for sure. The problem with blood pressure, well, amongst other cardiovascular issues, but the problem with blood pressure is we call it the silent killer for a reason. You could have very high blood pressure and have zero symptoms. And so that's probably truthfully number one, followed by blood sugar and cholesterol levels, in particular the LDL. I tell my patients, think of L for lousy. That's the bad cholesterol. That number, the pendulum has really started to swing. So Europe is always ahead of the United States in medicine, and their guidelines are usually 3 to 4 years ahead of ours. So I tend to look at European guidelines a lot because I know it's going to come downstream for the United States. But when I was in training and in medical school, the goal LDL was less than 130. Now it's less than 100. And if you have diabetes or have a history of a heart attack, it's less than 70. So what we've really started to see in medicine over the past really decade is that the lower the cholesterol, it's almost a 1-to-1 correlation in terms of lowering your risk of heart disease. So by far, easy stuff. This is like bread and butter, hasn't changed in many years, except for maybe the cutoffs, is blood pressure, blood sugar, and cholesterol numbers.
Okay. And I want to jump into my first of the controversies that are out there, and that is, so I currently eat a flexible diet, as do, we're proponents of, eating what works for you, tracking, working out, all of this stuff, and not being too rigid with any particular food. We don't cut out foods or anything like that. However, there are some camps out there in the fitness industry with food when it comes to cardiovascular disease and saturated fats, for example, or even the measurement of LDL cholesterol, not believing that it's as serious. Can you address some of those misconceptions of why understanding LDL and having it under a certain number is important for everybody, and what the links are in the evidence with that and cardiovascular disease? That one piece of it. The other, we can get into like low carb and all that later.
There's more links and research with this than probably pretty much anything else in
Mhm.
cardiology. I mean, I could pull article after article after article. And again, to my point earlier, that's why we now know that the lower that number, the less the risk of heart disease. Now, I think what's important is people take things to the extremes,
Mhm.
and you could have a very low LDL and still have a heart attack, or you could have a very high LDL and have no coronary disease. So a big part of it is the number. But what comes into that also is someone's genetics and what they're genetically at risk for. So you could have a very kind of normal-ish LDL. Let's say it's maybe 110, 115. It's close to being normal. But that LDL might be very sticky, or what we call atherogenic LDL. And if you have a very atherogenic LDL, it really doesn't matter how low it is. You're higher risk than someone that does not have an atherogenic LDL. And that's where some of these more advanced lipid panels come into play. In terms of diet, I am a big fan of pretty much everything in moderation is okay. That's always been what I stand by. Obviously, if I have a very uncontrolled diabetic, it's, well, let me back up. What I've realized is when you tell people a little bit, it's never really a little bit. It's more than, maybe a little less than what they were doing. And when you say no, then they'll still do a little bit. So for instance, my diabetic patients, I'll say, listen, no refined sugar, no this, no that, knowing that they're going to have a little bit. But, I think you'd be hard pressed to say, well, if I have an egg or two, twice a week, that something catastrophic is going to happen to me.
Mm-hmm.
And a lot of times that's where our medications come into play too. And I think my biggest frustration with the world right now is thinking that everyone's doing something for some pharmaceutical company to make money. It's frustrating. I have never made $1 off of any pharmaceutical company, but yet someone on the internet says that we do. I don't know where they're getting this information, but I'd like to know where my money is if that's the case.
For sure.
I've never made a dime.
Get those royalty checks. Yeah.
Yeah, I'm sure there's some margin of truth to someone somewhere, some CEO of some business, but when it boils down to it, your regular hometown good cardiologists look at data, we analyze that data independently, and we come up with the right decisions for our patients. And you'd be very hard pressed to find a cardiologist that's not, doesn't want to be famous for being different. Let me put it that way, that would say that cholesterol medications are going to harm you. I mean, there's just too many studies saying that they're not going to. Do I want to put patients on medications? No. But do I have to sometimes because it's the right thing for them and I want them to live a long, healthy life? Yes. So, it's a conversation that you have to have with the patients. And my most common quote in my office is, you can take one medication now, or you can take four for the rest of your life after you have your heart attack. It's your pick.
Yeah. I totally relate. I'm not going to criticize that either. And I've seen in my own family where someone, my own father included, has gone on medications, but then changed his lifestyle, was able to maybe come back off some of them, maybe not all of them. And at the end of the day, we want to give ourselves the best shot, I think, while also not being stupid. I mean, just I hate to say it that way, but not just, following the extreme kind of influencer, mentality here, like you said, against the medical profession.
Well, it's also about what's maintainable too. Sorry, it sounds like I've got a pig back here, but it's a French
No
bulldog.
worries.
It's also about what's maintainable as well. So when I talk to patients about diet and exercise, if I say, you should eat a diet full of X, Y, and Z, and they hate all of those foods, well, that's just not going to work. It's not feasible for that person. And so, every decision that is made should be a very educated decision between the patient and the doctor.
Yep.
And very personalized between the patient and the doctor and what's going to be best for them. But to say that we don't have so many tools in our armamentarium to help people not die of heart disease. I mean, 90% of heart disease is preventable. 90.
Yeah.
That's a staggering number. And we have so many things to help us prevent it, but yet we get so much pushback. Look at our life expectancy. We live a lot longer than we ever did before. That's not because we're miraculously more healthy. No, we're fatter. We're fatter than we've ever been in this country, yet we're living longer. That's because of medicine.
Yeah. So, okay, fair point. Now, the people listening to this show may be in a little bit of a different tier of the prevention side, where they are, trying to be preventative with their lifestyle. They are willing to, eat more whole nutrient dense foods. They don't want to cut everything out because they understand flexibility and sustainability is important, but they want to know, for example, dietary fats. It's confusing. There's, mono, unsaturated, poly, and they're saturated. We've heard that there maybe is a threshold for saturated fat associated with cardiovascular disease. And so 2 points there I would love to hear you help clarify is there a reasonable, say, limit to saturated fat in particular that we should be cognizant of? And is any of the research confounded in the populations with that level? In other words, if you have an overall healthy lifestyle with everything else, is that saturated fat limit as important?
Probably not. Again, I think it's very difficult. Well, it's very difficult to give a global answer on that because it really is so personalized to each person. I think probably from my experience and my research, I mean, obviously saturated fats, there is a link between saturated fats and cardiovascular disease. I don't think no is the answer. I think, really watching and being cognizant of it is probably the answer. More importantly is the effect on those saturated fats to inflammation in the body. And so the more research we do, the more we find out that it's cholesterol and yes, it's saturated fats, but really it's what's causing this inflammatory response in the human body, which is then leading to the cancer and the heart disease and the heart attacks and the this and the that. And so really it boils down to, for most, trying to avoid things that come out of animals, especially very big animals, because there's a pretty good link between that and systemic inflammation. So, we like things that grow out of the ground first, and then we like things with no legs in the ocean, and then things with little teeny tiny legs on the ocean floor. And then we kind of work our way up to where I would never tell someone ever that they can never have a steak or a hamburger or a hot dog, but should it be, definitely not a hot dog, but should it be the mainstay of their diet? Do I want someone eating, something that came out of a cow every day? No, because I can almost guarantee you their inflammatory markers are going to be elevated.
Is that measurable through any sort of like autoimmune type panels? Or I'm just curious, when it comes to inflammation, it's kind of a confusing topic for a lot of people because people will talk about inflammatory foods and they'll kind of overlap it with things like insulin resistance and sensitivity and a whole bunch of other things that get confusing.
Yeah.
Is there a way to measure that?
All very different stuff. Yeah. So we use something called a high sensitivity CRP or a CRP. There's CRP and there's a high sensitivity CRP. In particular, in cardiology, we use a test called a high sensitivity CRP, and that kind of gives us an understanding as to what might be going on in. Do you hear this poor thing?
A little bit.
Dog.
Yeah.
He's just talk about being fat.
We've got one.
The high sensitivity CRP gives us an idea of if there's any inflammation going on inside of the arteries, generally in your body, but more particularly the arteries of the heart. And that's what cardiologists really care the most about, is really that inflammatory response. You could have, so people kind of that are listening understand, like I said, you could have a very high cholesterol, you could have all of these problems, but it's usually an inflammatory event, some sort of inflammatory response that causes disruption of the arterial wall and the plaque that then causes the heart attack. It's an inflammatory response. And so, my take home for my patients is, listen, I'm really never going to tell you can't ever have anything. But if you love fish, I'd rather you have more fish than steak. And if you love steak, I'd rather you have the filet, not the New York strip. Like, there's ways of manipulating it some. But yeah, I'm not a no-go type of physician. I just don't think it's maintainable. And at the end of the day, I just want people to maintain health. I don't want them to be super healthy for 5 years and then fall off the wagon. That's not success in my book.
I totally agree. I mean, there's small changes that if anybody made them would be a big step change, right? It's kind of the 80-20, because I believe something like most Americans consume like 70% ultra processed foods or something. If you just flip that around, that's a huge improvement.
Huge.
Huge. You mentioned,
I even say, if someone could have like 3 vegan meals a week, and then we manipulate that to just 1 a day. Think about like a lunch with just like salad and like a balsamic vinegar and lots of vegetables. Like, I could never be vegan. So it's very hard for me to tell my patients to do that, but I know I could do 1 meal a day vegan. I know I can do that. I could eat oatmeal that's made with water or almond milk. And there's ways of doing this. And I think taking those it's like parking far away and walking instead of parking, at the closest spot. Taking those little steps is really what makes the biggest difference long-term.
Yeah, I hear you. And same thing. I'm an omnivore and I have occasionally a non-meat based dish here and there. I don't know if I've gone a whole day without meat, but that's just me. And at the end of the day, like, I know when I work with my like nutrition clients, if we look at something like saturated fat and it's way up there, then, there's some shifts that could be beneficial. And what you're saying, incorporating more plants or seafood and things like that will just naturally get you away from that. And so there's different ways to kind of look at it. You mentioned arteries, so that brings to mind the calcium score. Do you recommend that, the calcium, like that heart X-ray, or no? Is this a controversy?
It's a big controversy. So anyone who knows me is probably cracking up right now. I absolutely despise calcium scores.
Okay.
And let me maybe rephrase that a little bit. I despise calcium scores on anyone under the age of 60. The older you get, the more reasonable and sensitive and specific a calcium score becomes. Here's the science behind it. A calcium score measures calcium, calcium in or around the arteries of the heart. It does not look at, nor can it measure any cholesterol-rich plaque, which has not calcified yet. That process of calcification takes time. It does not happen overnight. So if you do a calcium score on a 45-year-old and the score is 0, then what happens with the patient? And let's say their cholesterol is high, and this is my problem with it. I get a patient that comes in, doc, and this happens once a week. Doc, my cholesterol is high. My primary wants to put me on a statin. I don't want to be on it. I want you to order a calcium score. No, because what's going to happen is I'm going to order that calcium score on a 45-year-old, and it's probably going to be 0 because calcium has not had time to form yet. And then what happens is that patient who might actually have cholesterol buildup in those arteries now definitely is not going to take medication, because now you've just told them what they want to hear. Now you fast forward 10 years and that person's had a heart attack when the medication probably would have prevented it had they taken it prior. So older patients, it's an okay test. And I don't super fight on someone that's kind of 60 and older. Questionable mid-50s, maybe I start negotiating. Never before mid-50s. Because you're just going to miss a substantial amount of cholesterol plaque that is not calcified yet and give people this false sense of security that everything's okay. I have horror stories of patients that have normal calcium scores and have had heart attacks and open heart surgery and you name it, that it's bad. I mean, I lecture doctors on this usually about once a year, and inevitably all of them come up to me. There's like a line out the door afterwards, like, oh my God, I've been doing this wrong all along. You have to understand how this works. So, it's a cheap test, but it only risk stratifies. It's kind of like giving you half-ass information. If I'm going to order something, I want to know everything.
I get it. Because it'd be one thing, I guess, if you said if the score was negative, that's the only time we're going to act on it. But humans don't work that way because the zero comes back and you rely on that.
So, in a 45-year-old, the only positive meaning of a calcium score is when it's not zero, because then you've got a real problem.
Yeah.
That you're 45 and you already have calcification.
That means
right?
It started early and it took that long. Yeah.
Right.
I'm glad I asked because I've heard that. I was asked to take one years ago when my cholesterol dipped up just a tad and it came down later. And it was like, what was the point? But I've heard people get recommended that. So now the listeners is more informed, and that's why I asked it. Let's get it. Okay. So I think we talked about a little bit about nutrition. I don't know if fiber is another one that comes to mind. I mean, for years and years, I grew up in the 80s and it was like fiber rich cereal, heart healthy and all that. Cheerios, right? I think they still have it on there. Tell us more about the link there.
Yeah. Fiber from a cardiovascular standpoint helps to increase the HDL a little bit, which is the good cholesterol, and decrease triglycerides a little bit, which is another type of cholesterol particle. I think more important for fiber is really colon health, if anything. It keeps your poop nice and soft and you get to have nice bowel movements. And there's a pretty good correlation between high fiber diets and less incidence of colon cancer, just like there's incidence of high animal protein, like high red meat diets, and a higher incidence of colon cancer.
Yeah.
So I think that's probably more the correlation now, less so for heart disease and probably more for colon health.
Okay. Yeah. And that's a good reason to eat your fiber anyway, your gut health and your digestion and all that. Okay. Let's talk about exercise a little bit here. Okay. So we're big into building muscle, strength training on this show. I can't shut up about it. I have tons of guests on all the time that talk about the importance of muscle, almost more important than weight loss for a lot of people in our population, just because they're not dealing with like significant obesity. But let's talk about the big picture. Like cardio, when you think of heart, you think cardio, and then you think cardio as a form of exercise. And there's just a strong, at least mental link and semantic link. What are your thoughts on overall training regimen for somebody who does have a healthy lifestyle and wants to have the best shot?
I think it's both. I personally, I'm not a huge cardio person because my weight training really is cardio. It's kind of both. My heart rate is pretty high.
That deadlift will spike your heart.
Yeah. And I think that's honestly, I tell my patients, I'm like, if you do high intensity interval training and you incorporate some weights into that, you don't need to do both. Like you're probably crossing the T's and dotting the I's, but sorry, there's a big jet going over my house. But resistance training, there's been some studies that show 15% decrease in mortality for resistance training and 17% decrease cardiovascular mortality. So there's strong data on resistance training in overall health and in heart health, for sure. And then I think more importantly, especially for your women listening, big decrease in osteoporosis. Big, really big. Like you don't want to take an extra pill every day, you go lift some weights because that's what's going to keep you from having brittle bones and ending up on medications like nasty bisphosphonates that we have to give women and men, but mostly women when they are postmenopausal and have osteopenia or osteoporosis. Lifting weights is the number one thing.
Yeah, I love it. Yeah, no, so that's huge. So 17% decrease in cardiovascular mortality from resistance training, and obviously osteoporosis, osteopenia, huge benefit for weight training. Okay, so obviously there's no shocking revelation there. You alluded to the fact that if you're training and maybe doing a little bit of cardio in some form or another, you're good. What about walking?
I like walking. I think, it's like, what kind of walking are we doing though? Are we taking a leisurely stroll around the block, or are we like really walking? For me, I don't buy this whole like 10,000 steps a day. I would rather someone walk than sit around all day long. Obviously, that makes me happy, but I don't consider that exercise. For me, that heart rate has to get up. You've got to get your heart rate up for it to be considered exercise. You want your heart to have to work. Moving all day long, hitting those 10,000 steps, will help to keep some weight off. You're obviously burning energy, you're utilizing your metabolism, so on and so forth. But for it to really be considered exercise in my book, the heart rate's got to go up. Like if you can carry on a conversation, like this is what I tell my patients, if you can carry on a conversation like you and I, it's not exercise.
So you mentioned walking, whether it's exercise or not, which is interesting because that wasn't precisely my question, and I'm not criticizing your answer at all. But what's interesting is I recently did an episode called, actually it just came out today, I think, or yesterday, Who Cares If Walking is Exercise? That was the name of the episode. And it was in response to this clip that went viral with Dr. Gabrielle Lyon, where she said like, well, I don't consider walking exercise. And it's interesting you say that because I agree, like walking maybe has other benefits if it's not done at this intense level. And we often classify it as non-exercise activity, right? Like,
Right.
so it matches there. So what you're saying is that from a heart health perspective, weightlifting is number one, some form of cardio that gets your heart rate is up number two. That's a pretty good metric. And then walking beyond that may have other benefits for just like calorie burn, metabolic rate, whatever. Is there any other? Okay. So I guess there's no other like health benefit that we wanted to focus on from low grade walking then.
Not other than just the obvious kind of benefits of just
Yeah.
getting, moving your body, which is what I tell
Yeah.
people half the time, just move, just get up and
Yeah.
move. Don't sit around all day long. Yeah.
Exactly. Because then you're not moving, which has its own negative association.
Hi, my name is Alan, and I just want to give a shout out to Philip Pape of Wits and Weights for being a huge part of the foundation for my continued health and well-being. Philip exemplifies a nutrition coach who demonstrates how much he cares. Philip works tirelessly and with dedication to provide coaching support and major content for us to use. He creates a practical approach from research, and Philip empowers all of us to use food as quality for our health. He is skilled in how to assess and direct nutrition. Philip creates a community full of wisdom, support, and camaraderie. In summary, Philip Pape is the real deal. He knows how to assess and direct nutrition, and he continues to steer me in the right direction. Thank you, Philip.
So speaking of lifestyle then, outside of training and nutrition, we've got, I know stress and depression are like on the CDC's list of risk factors, sleep, probably the whole mental side of it, social connection and all of that come into play mainly because of stress. What are your thoughts on that so it doesn't get too muddied for folks listening?
I think it's a big problem. If you just look generally at mental health as a whole, most people that have what we would call like low quality mental health are more of our physically unhealthy people as well. And so we start to wonder which came first, kind of the chicken or the egg, because patients that have higher, maybe consider themselves healthier, I shouldn't say healthier, happier people, they tend to be thinner. They tend to go out with their friends more, have better social interactions, maybe go to the gym with other people. So I think there's a big, big, big connection. People that have positive outlooks tend to have lower blood pressure, lower heart rates. People that, and there's been a few studies as well on stress and patients that think that they have a lot of stress or define themselves as having a very stressful life have higher inflammatory markers also, and higher incidence of high blood pressure, high cholesterol. So there's a big, big, big interplay amongst that. For sure.
Okay. So, and I like that you made the link like chicken and egg, because people always wonder, and I definitely talk about this too. The mental health is often improved when you go for a walk, when you work out, you hang out with your friends, right? Like you said, even just maintaining a healthy body composition and body weight. So that leads to like the question, is there one thing that underlies all of this? And is it really just maintaining a healthy weight and body composition, and really everything else is a corollary of that? Is that a stretch, or is that, reasonable?
I think it's generally reasonable. Again, if we're just looking statistically, yes, that's probably a reasonable statement to make. I mean, obviously I have thin people in my office that are not very healthy and have had heart attacks, but I think that's a pretty easy conclusion to make. Because a lot of people say, oh, well, I'm happy because I have this and I have that and I have an expensive car, but this might be patients that have very high stress jobs and they're really not that healthy. They just appear to be happy from the outside. And you really, as their physician, I can tell you that's not always the case at all.
So when somebody's in your office that visually appears what somebody would say is thin or quote unquote healthy visually, and they have high cholesterol, what's typically the cause there? Or what are like the top 2 or 3 causes?
Number one is genetics. You can't escape your genetics. You cannot escape. Let me say that again. You cannot escape your genetics. People listening, everybody must know. And if they don't know, they should dig around until they find out what, people have died from or what diseases they had in their family, because you cannot escape that. So I think that's unequivocally number one. Number two is, remember, there's such a thing as skinny fat, right? You could be skinny and have high cholesterol if you're not eating the right foods, to your point earlier. So you could sit around and have Cheetos all day long and not consume a lot of calories and be thin, but you're consuming awful foods with lots of fat and no whole grains and no whole foods. So that's a real thing. So
Yeah, I'm glad you mentioned that. Yeah,
factorial.
skinny fat. You're right, because that's why I say body composition specifically.
Yeah.
We often talk about fat loss versus weight loss because there is a heavy emphasis on weight loss, but not at all costs, right? Not if you're losing your muscle mass, your bone density decreases, and then, like you said, it could even lead to hidden or stealth things happening with your health, like cardiovascular disease, just because you look skinny. So it's important for people to know the spectrum, which then leads me into the obesity paradox, right? Can big be beautiful and healthy? I know you wanted to get into that. Let's talk about that, right? I guess we can talk about the movement and the body positivity thing. I don't need to get too much into the political stuff, but we can get into reality and what is healthy and what's not, and how we should be approaching this subject.
Yeah, I think people don't want to talk about it because you don't want to get hate mail and get hated and and I understand that, I do, but you will never come into my office overweight, number one, obese for sure, and have me not tell you that you need to lose weight. It's just not going to happen. Like, go find another doctor. My job is to make sure, do everything in my power to get my patients to be healthy and live long, fulfilling, good lives with a good quality of life, right? That's my goal. That is not going to happen if you're obese. It's not. It's just not going to happen. So, having someone like the way they look, feel comfortable in their skin is very different than you coming to a doctor's office and you being obese and me telling you that you're healthy. And it's a real thing, because what happens, we get labs on some of these people and, they'll be like, oh, I'm a healthy fat guy. And it's like, maybe for now, but that's not going to stay like that forever. And so my line that I tell my patients, and so I preface, I said, listen, I'm going to tell you something and you're not going to like what I'm going to tell you. And you're probably going to leave here really pissed off at me. And then you're going to come back and you're going to be thanking me. And they, I tee them up, I get them ready. And I look at them and I say, you tell me the last time you saw a fat 80-year-old.
Mm-hmm.
And they kind of sit back and I'm like, go ahead, tell me. Right? Because every once in a while someone says it, but statistically you don't. And they say, well, I don't know a fat 80-year-old. And I go, tell me why. I make them say it. Tell me why. And they go, because they're dead. I go, exactly. Because you do not live long lives in this country or around the world, period, if you're heavy, especially if you're obese. And it's like a one-to-one. The heavier you are, the more likely you are to die early. It's clear cut. And there's something to be said truthfully about being too big, even muscularly, right? There's also, that's still weight. So would I rather someone be very muscular than very fat? Of course, having adipose tissue. But there are a lot of like Mr. Universe, Mr. this, Mr. that, and all these people that they walk around like their arms can't even touch their sides, right? They walk around like this. Also not good. Weight is weight. So we want to be like long and lean and have good skeletal muscle mass with very little, as much as we can, of adipose tissue.
Yeah.
But it's not good.
Yeah. First, you just triggered all the lifters who are like,
yeah.
Who are you to tell me not to have all that muscle? No, but it's true. I mean, most people aren't going to be, I think, that big anyway, short of performance enhancing drugs. But, I do know a lot of lifters in their 50s who have a lot of muscle, and they're bigger. And you're right. Like, the metabolic markers tend to drift in the direction we don't want them to. But it's partly body fat too. Just to get that level of muscle, you tend to be gaining fat in the process unless you lean out. Right. So, but the thing you said about the 80-year-olds, I mean, it's so true. I've maybe seen large 70-something-year-olds, and they've got 20 different ailments, and they're like on death's door. And that's not a place we want to be.
The number one complaint, are you ready for this? The number one complaint is, well, two. Number one is, my knees hurt. Well, no shit, your knees hurt. You're carrying around an 80-pound backpack all day long. And that's what I tell them. I said, how do you think I would feel if I put on an 80-pound backpack and walked around all day long? My knees are going to hurt, my hips are going to hurt, and I'm going to be freaking exhausted at the end of the day. So don't come here and telling me that it's not your weight that's causing it, because it is your weight that's causing it.
Yeah, no, 100%. Yeah. And the whole thing, the big is beautiful, big is healthy. I guess we could separate the subjective side. People can say whatever they want about, attractiveness. But as far as loving your body and all of that, right? We have that whole body positivity movement. At least the way I put it is, if you love your body, you're going to care to get it into a healthy, state. And there's nothing wrong with being big now and having the desire to not be. There's nothing wrong with that. And you can still love yourself and go through that process.
Well, you have to. You almost have to love the process, right? Yes. You have to. You have to love wanting to be around. I was reading a book this week of just about optimism in life. And then a friend of mine posted something and it all kind of it kind of coalesced together. And it says, sometimes you have to do things today, not because of yourself today, but because of who you want to look back on tomorrow and say, I wish I would have done it. Right. So you're doing stuff for your future self. You're not doing it for yourself today. And that's a very good way of looking at everything. Just because someone's heavy now, but listen, shit happens. People gain weight. They go through divorces, a child dies, something catastrophic happens. We're human. Things happen to us. Weight fluctuates, stress fluctuates, life fluctuates. But it's about kind of getting back on track and loving yourself enough to want to be around, to want to live a long life, to be around for your children, to be around for your family. And I think that's kind of the most important take home point. I don't harp on people for being big. I harp on people for not wanting to change it and not loving themselves enough to change it.
Yeah. Yeah. 100%. And so if someone is in that state and they're listening and they're like, okay, I hear it and I want to change. And in fact, maybe I've wanted to change for a while and I may have taken certain actions to change and something is not quite working. I mean, I definitely deal with this all the time of like, I'm trying to lose weight or I'm trying to do this, or it's my hormones or it's my whatever, and it's not working. And there's usually some underlying practical reason for that. But what is your take on that? Someone says, I've got a lot of weight to lose. I'm trying. It's just not working.
I think, but I say that with everything, I have, not to break away from kind of the point of our, I have patients like, oh, I can't do it all. And I can't do this and I can't do that. And I can't take my kid here. I'm going to ask for help. You don't have to do everything yourself. If you find the right doctor and you're willing to have a great relationship, you'll find someone that can help you. And at the same token, I find that, again, we go way off the mountain sometimes and they think it's hormones or they think it must be this, it must be that. I'm doing everything right. No, you're not.
Yeah. Yeah.
No, you're not. Because everyone wants an easy answer. They want not an excuse, but they want something easy to put their finger on, to not have to be introspective and say, maybe this is me. Right. Yeah. And so sometimes it takes someone a little tough to say, listen, I'm going to help you through it. We're going to get you there. But you got to look in the mirror and realize this is not your thyroid. This is not, your hormones. This is you. And we got to get you back on track, and we'll check everything else and we'll make sure everything else is optimized. But at the end of the day, 99% of the time, obesity is not due to some pathophysiologic process. It's due to someone creating poor habits.
Yeah. And that's an empowering message. If we want to spin in the positive, that's an empowering message because it means you're not at the whim of fate. You've got total control over the situation.
That's
and like
correct.
you said, just ask for help if you're having trouble, or maybe you don't understand fully the context or the strategy that you need to be successful. And that's where others can help you, other experts. Honestly, that's why you go on podcasts and such. That's why I have this. It's like to share as much information as we can based on whatever evidence we're aware of, so people can make those behavioral changes.
Yeah, and different things work for different people. And that we know. We know intermittent fasting might work for you. It might not work for me. There's, but you got to tease through all the BS and kind of find that. And you've got to sometimes also step back and say, okay, well, why is it so miraculous and so wonderful? Because someone's making money on it. So you have to, if rapid is in there, rapid weight loss or miraculous weight loss, like these are not words that any physician or any clinic should ever be using, because that's not healthy or safe either. It's a stepwise approach. It took you years to put on 50 pounds. It's not going to come off in 3 months.
Yeah. So if somebody then is like, okay, now I hear you here, I'm ready to make a change, I'm going to seek help. Let's talk about the medical side, since that's where you're coming from. How does somebody find a provider that is actually going to help them? Because I know there's a lot of skepticism these days. I know there's like gaslighting and things like that out there, especially with women's health. And there's a whole spectrum of quality out there, right? And it depends on where you live and your insurance and so many things. Yeah. How does somebody find a good provider? What are they looking for? And then communicate with that person to get what they need.
I think the first and foremost is finding a provider that, number one, you like, which that's step one. You have to like your doctor. If you don't like your doctor, it's not going to go well, and that you feel like you communicate well with. Two, a physician that really does focus on prevention, not just curing disease or taking care of someone because they're coming in with what we call their chief complaint, right? That's, for your listeners, that's what doctors say on the form, and you fill a chief complaint. So we listen to complaints all day long, basically. Unfortunately, most preventive visits, with the exception of an annual physical, is not covered by insurances. So it might be something where someone that's listening has to say, listen, I'm going to, I've been spending the money on smoking, or I've been spending the money on food. And you might just have to step back and say, okay, well, I'm going to spend the money on this now. And you might have to pay out of pocket and go without your insurance to have the time to sit down and talk to, maybe your current doctor or your new doctor about what your goals are. Because if you're wanting to sit down and spend 20 minutes, 30 minutes with your doctor going over different goals and what you're trying to achieve, it's going to be hard to do if you're going through insurance, because that truthfully, I know it's like, woe is me, but the reimbursements are so awful that most doctors just aren't going to do that. So I think finding a true weight loss, like a doctor that's board certified, maybe I'm not, but I'm a cardiologist, so I do it, but board certified in bariatric medicine or obesity medicine that understands this disease process, because it really, there's a big mental component to this as well. And those physicians will help get through that and break those barriers.
Yeah. Isn't it funny that you're right. We spend so much money on so many frivolous things in our budget and are not willing to spend on healthcare, partly because, like you said, we think insurance should cover stuff. So if it doesn't, it's like not even in our sphere of existence. Right. I hear that with hormones all the time. My own wife too, we have to pay money for hormone specialists, and it might be functional medical care. It might be, board certified, whatever. It tends to be out of pocket because insurance doesn't cover it. And then, like you said, you've got to like the relationship. I've heard so many people who just dwell on somebody who's telling them that they're lying, or they don't believe them or whatever. And that's the gaslighting piece of it. But there's even just somebody who's an a-hole. You just don't like them.
Yeah,
it's like,
listen, I hear that all the time. Like, why are you here? I hated the other cardiologist. Dude's an ass.
Yeah.
I'm like, okay, cool. Welcome.
Yeah. There you go. Yeah, exactly.
I mean,
be nice.
look,
be nice.
At the end of the day, you just have to care a little bit. It's really not that hard. Like we became doctors really for two reasons. We like medicine and science. We like people. If you don't like people, you shouldn't be a doctor, or you should be a pathologist and look at slides all day long.
There you go. Yeah. Or a surgeon's kind of like in the middle. I would
surgeons.
say.
Yeah, we like
I'll talk to you for a little bit, and then
or anesthesia, right? You just night,
Yeah, exactly. Perfect career choice there. Okay, so let's see. We talked about mental health. I guess why don't we end with, since you mentioned being nice, your be nice philosophy. I mean, I love the science of kindness, of positive psychology, of all that kind of stuff, and that seems to tie in well with mental health. I mean, tell me more about that.
Makes me feel better. Listen, we all have our days, and trust me, I've had my moments. Like, everybody has their moments, but sometimes I think it's better to just step away, take a few breaths, and not let the excitement get the best of you on most days. And my patients will say, like, some days, like, are you okay, doc? You seem a little off. It's like, yeah, I'm having an off day. But my husband's a lawyer, and he says something, and I said, it's so true. Because I say, it's not what you say, it's how you say it. And my husband-in-law, they say there's a tone and a tenor, right? It's the tone and the tenor. It's not what you're saying. It's how aggressive you're sounding, or the tone of your voice and the way that you're saying it. And that's something I think a lot of people could probably benefit from. And I think there's nothing wrong with just kind of saying, you know what, I need a minute, and just kind of step away and clear your head. I mean, the world's a very chaotic and busy place, and we're all hustling and trying to be the best and trying to make the most money, and thinking that what people look like on social media is actually what they look like in real life, which is absurd. And I think part of it too is just being truthful. My best friend says, say what you mean and mean what you say. Mm-hmm. And I think there's something to that. Simple example, if I know that someone asked me to go out, I don't know, for happy hour, and I say, okay, yeah, maybe, but I know in my heart of hearts, it's a no. Just say no. Because it's going to create another problem for you in 4 hours when they come back and ask you again, Yeah. And sometimes it's just say what you mean and mean what you say. Like, be nice about it. Say, you know what, maybe next time it's not, that's not part of my journey today.
Yeah, I love that. Honest communication. We still read the physical paper, which, if you could believe it. And they have like the column where somebody writes in for advice. And it's always like, you don't even have to see the question. The answer is, you need to talk about it. Like, the answer is just communicate.
Yeah. And communicate when you're not upset.
Yeah.
Because you're never going to get anywhere communicating when you're upset. Sometimes just, taking a minute back and be like, you know what, let's talk about this tomorrow, but let's hash it out. But most problems in this world are because someone didn't communicate with someone else adequately.
All right. Last segment here. I did have some questions from our community. I think 2 of them have already been answered. So I'm going to focus on the third one. The first question was, how much cardio? I think we addressed that. The second one was, does genetically elevated LDL perimenopause predispose you to higher cardiovascular risk when everything else is in check? And I think, again, you said potentially yes, if you have
Yeah.
higher LDL. I don't know if there's any more nuance to add to that, right?
A little bit. I'm a
Okay.
big fan of hormone therapy and the
Okay.
perimenopausal menopausal period. I think that
Okay.
the Women's Health Initiative was very much skewed very early, in the 90s and early 2000s, and now we're realizing that hormones, probably the pendulum's shifted back, and we should probably be offering a lot more hormones. But yes, it's like when you're pregnant, if you have high blood pressure during pregnancy, the likelihood of you having high blood pressure later in your life is also very high. So to answer that question, yes. I mean, if you have perimenopausal increases in LDL, then there is a higher likelihood of having cardiovascular disease for sure.
Okay. So even, and that's kind of leads to a side question. So even if you have genetically higher baseline LDL from a fairly young age that never goes up, let's just say it just stays that way your whole life, does that still mean you have a higher cardiovascular risk? Okay.
Yes.
You're nodding yes. See,
Yeah.
that's important for people to realize, because sometimes people talk about, well, no, if that's your baseline, and then it's
No.
really only if it goes up. You're saying that there's an absolute.
No, it's not like
Yeah.
poops. Like, I'm a twice a day pooper. I've always been a twice a day pooper, and the other person's I poop 3 times a week, and that's me, and that's normal for me. No.
Okay.
No, if
That's
you're
good.
if you have
That's
a
good clarity.
genetically elevated LDL, you are genetically predisposed to having heart disease.
Okay. Good. Good to know. And then the last one, perfect segue. You mentioned HRT. And I guess the question is more, well, this was actually from a man, but I mean, I think it would apply to both. That was for testosterone. For women, it could be all the other forms of hormone replacement therapy. And it was, this is a long question. I should have shortened this. Oh man, this is a very long question. So much information out there. Most GP doctors and non-specialists continue to spread. For example, androgen induced erythros. Okay, you know what? Forget this one. This is a very long, detailed one I'm not going to get into. I'm going to shorten it to HRT and cardiovascular health. Are there any concerns?
Generally, no. Here's the thing with testosterone. I'm going to focus on testosterone
Okay,
since I think
let's
that's
do
what
it.
that person was talking about. The thing with testosterone is we tend to overdo it because men feel fantastic when they're on all this testosterone. There's also something to aging, right? If you're 65 and you feel like you're 20, it's kind of not normal. I don't want you to feel like an old 65, but I also don't really want you feeling like you're 20, because the way you feel and what's going on physiologically inside your body are very different. So my rule of thumb with testosterone is, and really the guideline rule of thumb is having low levels and having symptoms. So you're fatigued or you have a low sex drive, these kind of things. And this is when it calls for appropriate testosterone supplementation. By appropriate, I mean we supplement it within normal range. It can be the upper limit of normal range, but we don't want to go super therapeutic with testosterone. The
PED
reason
range.
is,
Don't go into PED range. Yeah.
yeah, the reason is I can guarantee you testosterone levels are too high, cholesterol goes up, blood pressure goes up, higher risk of clotting, pulmonary embolisms, coronary clots, big risk. That's why you see the hemoglobin go up so much. And that's a real risk. I've had multiple patients in my practice end up with open heart surgery, and they had 0 risk factors other than inappropriate testosterone supplementation at younger ages. So I'm not one of those, I don't have a problem with it, but it needs to be done appropriately. And you have to be very careful weighing the high from the symptoms and is causing some metabolic derangement in the body. It's kind of flip-flopped for women a little bit. There's no real studies that say, like, if you're on estrogen, you're going to decrease your risk of heart disease, but it also doesn't increase it. And so for women, we really treat symptoms, not so much numbers. We don't want to overdo it. But for women, it's very much symptom driven in terms of hot flashes and fatigue and insomnia and things like that. But we do know unequivocally that women that get estrogen treatment and perimenopause and menopause have a lower somehow still have a lower incidence of heart disease. They have a lower incidence of high cholesterol, lower incidence of hypertension long-term, and most definitely lower incidence of osteoporosis. So it kind of cuts both ways a little bit differently than men and women.
No, it's good to know the difference. And I wasn't aware of that at all. And yeah, testosterone on the men's side, it's still controversial for lots of different reasons, especially in the world of lifting, where men would love to be diagnosed with low testosterone so that they can go on supplementation. But one more thing related to that, this gentleman was talking about polycythemia, which I think is like a blood cancer related to this. I don't know where that comes into it.
No, well, polycythemia is, he's probably referring to having an elevated hemoglobin from the testosterone supplementation.
RBC,
And that's where the risk is. That's where the real, so it's just interesting to me that some men, they want this testosterone to be so high, and then they'll go like literally give blood. It's like, well, just think about that from a common sense perspective. Like, how good do you think it could be to give yourself something where you have to go give blood because of the adverse effect it's doing in your body, right? So it's
Yeah.
kind of like a common. So if your testosterone is so high where you have to go give blood, you're overdoing it.
Okay. The last part of his question was a potential preventative measure of giving blood regularly, power red donations.
Yeah,
So you hit the nail on the head. You know this stuff.
They're probably overdoing it.
Yeah. Okay. No, that's good to know. I think that's all I have there. So, I do like to ask guests, Tiffany, because this has been super enlightening. There's a lot of moments of where I learned, I'm sure, and like the calcium score, things like that. Is there a question you wish I had asked in this conversation? And if so, what's your answer?
Probably, do I take my own advice?
Sure. Let's go there.
Yeah, generally I do. I try and eat, and this is, I think you have to practice what you preach. I generally eat very well. And there are days where I don't. And there's days where I maybe have some crap that day because that's just how my life is going that day. And I'm starving and I don't have time to eat something great. But generally I eat well. Generally I try and exercise at least 3 times a week, and I exercise, and I try to meditate, and I have a little meditation device that helps me meditate. Yeah. I mean, I'm definitely a practice what you preach. And I bring that up because a lot of times people say, oh, it's easy for you because, whatever, you're thin. But I make a very concerted effort. Like, I'm crazy and I weigh myself every day.
Mhm.
I get on the scale every day, and I like my numbers to be within a certain range. And when they're not, I do whatever I need to do to get them back down, because that's what works for me. But yeah, I truly practice what I preach. I try and have a positive outlook on life. And again, I have days. I've got bad eating days. I've got bad mood days. I've got bad everything days. But I think, being happy, and I can say this now, I'm 38. I'm probably the happiest I've ever been in my life because I kind of just got this stuff figured out now. So I was giving a lecture to my 8th grade alma mater, which is so cute. And I was giving a speech, and I said in my speech, if it doesn't make you happy, make you money, or make you healthy, it's a waste of your time. And that's just the truth, right? You have to go to work to make your money, and you have to, you want to go to the gym because you want to be healthy, or you eat well because you want to be healthy. Other than that, if someone or something does not make you happy, probably should get rid of it, because happiness is truly number one.
Yeah, I totally agree. And I mean, you talked about before not being perfect and just taking the micro steps, taking the little steps along the way. And anyone's listening who's like, well, yeah, I'm far from what Tiffany's doing today. It doesn't matter. You are where you are. Like, just to start taking those steps going forward.
I'd say, honey, my life 7 years ago was a hot mess express. So you got to just,
we all have to improve.
You got to take those baby steps. But then once you get there, it's almost like that sense of like nirvana and enlightening. Like, I can't imagine getting there again. Because once you get it kind of figured out, what's important and not important in your life, and not even talking to, like, when you go around people and you just feel their negative energy, like, just you gotta go. They gotta go. I've gotten rid of people. Like, I don't have anything bad to say about you. I can't be around you anymore.
Yeah, no, I can totally relate. I'm all about positivity in that sense. Some people get sick of it, and I'm like, well, yeah, you're not in my sphere anymore. I'm just kidding.
That's a you problem. That's not a me problem.
Yeah, exactly. And it's funny because I'm 43 now, and I tell people, like, I got in the best shape of my life when I was 40. So I mean, at any age you can start. And it took me forever to start figuring stuff out as well. I'm just curious about your exercise 3 times a week. What are you doing these days?
So I actually have it behind me, my little tonal.
Oh, tonal. Okay, all right.
So I have
Very
my
cool.
tonal. I do that like once or twice a week. And then I go to the gym with my husband, although I don't work out with my husband because I jokingly call it his old man workout. He works out people that are a little bit older than him. It's kind of like their guy time. They're not really working out. It's bullshit. They're not really. But I go to the gym, and so I walk at inclines. I'm not a runner. I never have been a runner. Again, everyone's different, right? Like, I have the body of a runner. You would think I'm a runner. I cannot run. I get side splints, and I've never been able to do it. So I walk at inclines, and I do a lot of high intensity interval training. I do, I really kind of focus on muscle groups. I do bis, tris, lunges, all that kind of stuff.
Cool.
Yeah.
Awesome. Yeah, no, the walking, I don't like running either. And I used to be anti-running, even in when I talked about, like, not only do you not have to run, you don't have to run ever. There used to be the running kills your gains thing. That went to the opposite extreme, of course.
Well, I'll tell you what running does do is it really can, if you're, especially on a treadmill, if you're not running like outside in like terrain, it will jack your knees up.
Oh yeah. Yeah. That hard,
Yeah.
like,
Yeah.
can't
So again, it's
tread
like
thing.
thinking
Yeah.
about the whole picture, right? Like, okay, well, how can I keep my weight off, get my cardiovascular and not like hurt something else? And like, but okay, walking in inclines will do that, right? So it's just, it's what your individual goals are. That's all. Some people might have a goal of, I really want to run a marathon. It's very important to me. I want to do this. Okay, well,
Yeah, exactly.
I don't really have that fire. So yeah.
All right. I got a video issue again.
Uh-oh.
Okay. I think you're good. All right. So Tiffany, where can listeners learn more about you and your work?
My Instagram, I guess. So my personal one is Dr. like Dr. Tiffany Di Pietro, Dipietro. My business one is Di Pietro Health. And my website is Di Pietro Health. I had to think about that. dipietrohealth.com.
All right. Dr. Tiffany Di Pietro at Di Pietro Health and dipietrohealth.com. I will put those all in the show notes so listeners can find you. And this has been an awesome conversation. I'm glad we met. You came on here. I love your positivity and so much wisdom. Keep doing what you're doing. And thanks again for coming on.
Thanks for having me.